Like, the topic which I'm trying to cover is not confined to one specific disease, but we will be just trying to have a look on whatever possible optimization we can get before any surgery, whether it is emergency surgery or whether it is elective surgery. Okay. So Jamil, uh, can you listen? Okay.
Yes, sir. Assalamu alaikum, sir. You are talking
So
about
if
me?
we just if we think that what will be the optimization which we can get in a patient going for any elective or emergency surgery. So what will be your approach if you have a patient with asthma? What can you do?
Sorry, is patient with asthma.
Yes.
Hello, sir. Are you listening me? Actually, I am now in Pakistan. There is some
Yes.
problem in the
Yes. Yes.
signals,
Yes. Yes.
weather
Please.
problem.
Please. Yes. Please.
Okay, sir. If sir, patients came to me with known case of asthma, then I will first assess the patient how the about the severity of the asthma, and I will take the history,
Jamil, just try to.
medication. Uh, Yes, and also I will ask about the how is compliant with the patient. Also take with the previous last episode of the asthma, from which I can assess the how it asthma is controlled. And the current condition, I will assess patients about inspections and
What is the
and
what is
examination
the
and some
beds?
investigations.
What is the bedside test to see the severity of asthma?
Spirometry, sir. If we go bedside test spirometry, then we
PFR,
can assess the
peak expiratory freedom.
yes. In spirometry, then we see the yes
And this,
force expiratory volume over 1 second and peak expiratory flow rate. There we can also assess, and also there is force expiratory volume, especially with the mid expiratory volume 25 to 75.
okay. So now what can be you do? You evaluate the patient. So your answer should be that I will be evaluating the patient. How much is the severity on the basis of history, examination, and investigation, and then what are the options for you to do? What can you do?
Yes, sir, I will just see the patients how is but the surgery, and how is the patient's optimized, and how we can the further optimize. If patient is definitely in acute severe asthma, actually I go for first with the management with acute severe asthma. It's back-to-back nebulization with beta 2 agonist, and if there is any infection, chest infections, also definitely we take the pulmonology consultation for this patient to manage first the acute episode of asthma and acute respiratory infection, and uh,
First
maybe in
approach
this
will
time
be your first approach will be airway breathing circulation. Then you will be considering certain things: oral steroids, nebulization with apratropium, with nebulization with beta agonist. Okay, and then what other, as you told, any infection, and if there is any element of infection, then you will be giving this thing. You will be following the response with PEFR. Okay, and clinical sign symptoms. Okay.
and I will also assess the reversibility. How it's if definitely 12 or more than
Listen,
12 persons
Jamil,
should
Jamil,
be
I am expecting a better answer from
sorry.
you. What is difference between asthma and COPD? We are discussing about asthma, not COPD. So there is asthma is definitely reversible.
Sorry,
Okay.
reversible, yes.
So now this patient is going for a surgery. So this is this patient is having sub-reactive airway. Okay. So
Yes,
this
sir.
is what is
Sensitive area.
you have a patient with reactive airway. You will be trying to avoid airway manipulation. Okay.
Yes, sir. At the time of induction, especially time of laryngoscopy, and
Not
if
only
I go to
laryngoscopy. Jamil, make your answer better. Okay. Airway manipulation in light plane of anesthesia should be avoided.
yeah, actually, it will possible by the next sentence that I we do the airway manipulation in a deep phase of means anesthesia.
Yes, this is one thing. And then you are avoiding the drugs, like which drugs which are histamine releasing,
Like histamine releasing, like morphine and
or
for opioids and pentol, barbiturates, like means and
so vagal stimulation. Vagal stimulation will result in increased vagal tone and it will be
bronchospasm. Yes.
bronchospasm. So the things which are against are beta 2, and which are like you have to maintain a balance between beta 2 and muscarinic receptors. Okay. So you will be avoiding airway manipulation in light plane of anesthesia. You may avoid, you can go for regional anesthesia techniques. Okay. You
Yes, sir.
can
If there is any possibility for
will
regional, or if there is like if we can go supraglottic, if there is possible, if there is no
mhm,
risk of aspiration in some
supra
surgeries, and I
supraglottic,
preferably go to yes, use
and
the
you will be
supraglottic
using
equipment.
lidocaine. The other things which should be in your mind is lidocaine, magnesium. Okay. And like in
Ketamine
inhalational
also in
agents,
cases of
inhalational agents, which is better for you is halothane and sevoflurane.
halogen and sevoflurane is better option.
And for induction, desflurane and isoflurane are not a good choice,
Yes,
but
I
they
will
can be
write
used.
isoflurane.
But
Yes,
they can be used
for
for
induction,
maintenance.
they
But for maintenance, the rule
yes, sir.
is all inhalational agents cause dose dependent bronchodilation. Okay. So this thing should be in your
Yes, sir.
mind. So you will be thinking that this patient can be at risk of any allergy, so you will be avoiding NSAIDs. Okay. Not all asthmatic patient, but you other thing you should be in your mind is NSAIDs. Okay. So
Yes, there is 10 to
these are
15% which are yeah, they have means reactive airway due to the use of and non-steroidal inflammatory drugs.
actually
And also, sir, I will consider the airway ventilation strategy. Means in this
listen.
patient, in they have obstructive pattern.
Yes,
Yes, sir.
just a
Sorry.
second. Optimization and anticipation. The curse of our discussion today is optimization and anticipation. Okay. So another anticipated thing will be intraoperative bronchospasm.
Uh, Bronchospasm, yes, or
So
intraoperative development of
what will be the
intrinsic
what
peak.
will be the differential diagnosis for it?
Yes, sir. GD will be from anaphylaxis shock or anaphylaxis, a
Okay.
foreign body aspiration, like
Foreign
or
body.
maybe it's gastric this foreign body excretions, or kinking of the tube or any circuit.
You
Patient,
are not. Listen. The thing is that your answer may be that you will be ruling out serious problems, okay, like pulmonary embolism, okay, in which or
yes,
anaphylaxis, for example, in which there is definitely hemodynamic instability. Okay. So if it is not there, then it may be simple ones. For example, maybe light plane of anesthesia,
Secretions might be
light plane,
like
okay,
anesthesia,
secretions,
secretions. Yes,
okay.
maybe some
Another
might be
differential,
including
endobronchial,
intubation.
endobronchial intubation,
Intubation.
okay. Any problem with the valves, breathing circuit valves, okay. So this may all be,
Yes,
these
sir.
are
I
small diameter endotracheal tube. It will have more resistance, so more airway pressures. And you will be looking at that whether it is peak pressures are high or plateau pressures. Okay.
peak pressure will
So
be high. High, I mean the high
yes.
peak pressure.
So the theme for the discussion at the moment is optimization and anticipation of possible problems. Okay. So if you just add on to see with what will be the extra thing in COPD, other than these things, that there will be definitely there will be antibiotics, there will be steroids, okay, there will be incentive spirometry,
Spirometry
okay, there will be chest physio,
and steroids also.
steroids have oral courses, or and then postural drainage, okay, management of heart failure, which is common in these patients. Okay. Here you will say that reversible component
COPD.
of COPD. Okay. So antibiotics, also beta 2 agonists, apratropium,
Yes,
nebulization
anticholinergic.
steroids, and then
Inhalational steroids might be
yes, inhalation steroids, and then what else? This one we have discussed. One thing it slipped out of my mind is montelukast. Okay.
membrane stabilizer agents, both in asthmatic patient and COPD.
Yes, both in this one and chromoline sodium. They don't have any role in acute management, but they have role in the maintenance and optimization of the
Chronic,
patient.
yes, G2, yes,
Okay.
yes.
So, and then again, all the consideration. Okay. Now, again, the same thing can hope and can happen. In addition to intraoperative in broncho increased airway pressure, what else can be there in COPD? Which can be there in asthma as well,
Also,
but
sir, yes,
here, what can be occurring? To very specific.
chest infection also in
No,
most
Jamil,
of the time
you
there is
are
tension
not
of us.
understanding the question.
Sorry.
In the table viva, you don't have time. Okay. So you have to think, and that's what I'm doing the practice. Okay. So intraoperatively in COPD patient, other than bronchospasm, the thing which can occur is pneumothorax because of ruptured bulla. Okay.
Okay, sir.
Another important thing which can occur in COPD, I'm telling about practical things. This patient has O2 drive, low O2 drive, and baseline increased CO2. So if you lose this,
Yes.
then patient
PO2
can
if
go,
genoid will decrease.
then patient can go in
Postoperative
parenteral.
genoid
Okay.
depression.
This
Yes.
this is the thing which you have to always keep in consideration. Again, I'm repeating, airway pressures. Okay. Avoiding
Pneumothorax, risk of
uh,
pneumothorax intraoperatively,
yes, avoiding airway
and
manipulation.
have to maintain a saturation between our PO2.
Yes, you have to keep in consideration this thing. Okay. Then as what you were saying, that we have to maintain the higher expiratory time. Okay. and
Yes,
judicious use
ventilatory
of
strategy,
judicious use
uh,
of PEEP,
IE ratio,
PEEP,
fluids,
PEEP,
PEEP
judicious
also, sorry.
use of PEEP, and look for generation of
Keeping
auto
eye
PEEP.
on monitor to about the intrinsic or auto PEEP.
Yes. Another thing is that if you are increasing the expiratory time, if you are not increasing the expiratory time, then there are more chances of auto PEEP. Okay.
Yes, there is air trapping and
Tapping and
definitely it
auto
will
PEEP.
develop as auto PEEP.
So, so just recall air, like quantifying or looking how is the reversible component in COPD, or how much is the severity of asthma. Okay, and then you are making a plan in which you are avoiding airway manipulation or using supraglottic airway devices, or doing airway manipulation in in the deep plane of anesthesia, avoiding the drugs which can release histamine, avoiding the inhalational agents which can cause irritation of airway for induction, and then you are trying to avoid the medications which can cause and you are taking care of the surgical steps in which there is increased vagal tone. Okay, and then other than that, you are avoiding, you can go for pressure control ventilation, and you have to look for airway pressures, and this patient can develop pneumothorax if there is bulla. So this is what is evaluation, optimization, and anticipation in the patients with COPD and asthma. Okay, so now hypertension. How can you optimize a patient with hypertension? So of course you will be evaluation on the basis of history,
Yes, sir. I
examine
just evaluate by the history, and
history,
yeah,
and then
the
you will make out risk
how
factors.
long?
Risk factors. Okay.
Yes.
Of course, because actually we are dissecting the topic in a slightly different way. So whatever you are saying is not wrong, but I'm just trying to cover in a slightly different way. So you will be evaluating not only the control, okay, but how much is the end organ damage. Okay, so end organ damage,
Yes.
you
Mhm.
will be looking for
Starting
macro
from the
and
CNS,
micro
there is microvascular vascular
vascular
complication.
complications. Okay, this is one thing. And then how much is the control? So if it should not be class 3, okay, for elective case, if it is in class 3, you have to postpone and optimize the case. Okay, and if there are risk factors and end organ damage, then you are referring the patient for evaluation. Of course, you will be taking the history, you will be doing the examination, and you will be doing the investigation. You are looking for individual antihypertensive medications. Okay, antihypertensive, and you have to anticipate for side effects
Complication
of,
is how much the dose he is
yes,
taking
how much
and how is
individual,
compliant.
like for example, UL group AC inhibitors, you can expect hyperkalemia. Okay, and you can expect dry cough. Okay, and you can expect exaggerated BP
As
fall.
also, yes, also angioedema, BP
uh,
fall, hypo, arth-
no, no, we are specifically we are discussing about the patient with hypertension, either control, needing control, or what things you are anticipating. Okay, so in AC inhibitor, if you have patient with beta blockers, you can expect decrease heart rate which is resistant to atropine.
atropine, intraoperative, yes.
Okay, and if the patient is simultaneously taking calcium channel blocker, there will be exaggerated chances of and another thing is that
Bradycardia.
you have to tolerate lower heart rates. Why I'm using this word lower heart rates? Because majority of time, if you give atropine or glycopyrrolate to this patient, the suddenly heart rate will increase crazy. So it can increase, or blood pressure can increase suddenly. Okay, so you can have both sort of responses. So you don't go for rush for controlling the heart rate if they are slightly on the lower side. Okay, You can avoid, you can use by other things to maintain them. Then another thing will be if your patient is taking diuretics.
Until unless there is a compromise of cardiac output, then definitely,
Yes,
I will go. Otherwise,
like overall, yes,
yeah,
overall circulation is not
with
hampered. Patient is not hemodynamically collapsing. You will not only treat the heart rate, because you know that the patient is beta blocked. Okay, so this is, so if your patient with diuretics, you are expecting electrolyte imbalances. Okay, so you have to think about it. And what problems can occur in a hypertensive patient? Laryngoscopic stress response.
yes,
It
right.
can
Have to
be,
blunt before.
you have to blunt. What
Yeah.
will be the exact answer? No extra thing. What will you say to blunt the laryngoscopic stress response? Avoid airway manipulation.
Deep phase of anesthesia. Yes, yes, well.
Avoid airway manipulation. Go for other technique or LMA, also like supraglottic. Okay. And if you have to do it, you will be avoiding. What will be the first thing? Short laryngoscopy time. Then what else? Beta blockers. What else?
IV lignocaine prior to induction.
Lidocaine. Lidocaine IV versus spray. Okay. What else? Fentanyl or remifentanil or any opioid. Okay. And short acting beta blocker, for example, like esmolol.
Yeah, sir, your voice is
Just a second.
Additional bolus dose of propofol 0.25 mg per kg prior to intubation.
Yes. In deep plane. Okay. So you have to avoid laryngoscopy. So this is one thing. And the other next thing will be roller coaster phenomena. Which is called as sudden swings of BP. You do the laryngoscopy, you give the induction doses. Okay. Sudden drop. Then you do laryngoscopy, sudden up. Then you give another, you intubate and you deepen the anesthesia, again drop. Then they are giving the NCN, again up. So up, down. This is dangerous. Okay. So this is called as roller coaster phenomena or swings of blood pressure. So the target in hypertensive patient is to avoid this roller coaster phenomena. Okay, roller coaster goes up, down, right, left. So the purpose for you is to control the roller coaster phenomenon. So, and also you can have arterial blood pressure, intra-arterial blood pressure monitoring to avoid this thing, and you can use titrated doses. Another way to avoid is to use preemptive analgesia. Preemptive analgesia. Okay. So you can give paracetamol and this one NSAIDs. This will give you a cushion in between and you are maintaining the depth of anesthesia. Okay. So am I audible or there is problem?
yes, sir. Actually, yeah, we have some signal problems. There is no light. I think might be due to this weather outside also.
What
Some
about others?
thunderstorm.
What about others? Other people are listening to me. Am I audible to all of you? Please, if you have all are facing problem, then some problem with me.
No. I think it's with me because also I faced with other ones. But you are clear. I think with other.
Yes, I want to listen from any other people. Rabia Basri, Ali Raza, anyone please speak out. Are you listening to me clearly or no? Hassan?
Yes, sir, you are
We
clear.
can hear you.
Okay, thank you. So this is how you will be anticipating. Okay. Then another thing that how to to manage hypotension in a hypertensive patient, what should you do? Because you expect exaggerated response to anything you are doing. Okay, you have an angry bird which is responding to anything. So what you
optimization of fluid status
yes, okay.
as they
So
are
it is
hypovolemic.
you are hypovolemic. Okay, so it is better you have this arterial blood pressure monitoring that will give you, because even if you are doing repeated blood pressure readings, there will be a gap. So it is better to have arterial blood pressure monitoring, and you can follow the stroke volume variation, which will be giving you an accurate way. Okay, so volume replacement is one of them, and good analgesia is one of them. Okay, and don't react too quickly. Okay, too quickly, because if you are doing too many things together, there will be chance that this patient will go in hypotension. And what will be the problem if this patient goes in hypotension? What will be the problem? That the cerebral autoregulation curve is shifted to right.
Shifted to the right, they have high pressure for their organ perfusion.
Relatively higher pressure. So if you don't maintain the blood pressure, there may be a hypoxia. Okay, so this is that you don't have to let the patient too much more than 20 to 25%, 30% of the baseline. Okay, so this is one thing. And another thing is that the other factors you have to go slow one by one. Yeah, like you can always look for anesthetic management rather than immediately jumping to medications. Like anesthetic management is analgesia. Anesthetic management is use of like manipulating the inhalational agent. Then you can have a infusion of propofol or dexmedetomidine, okay, which will give you a very good control of blood pressure and heart rate. Then another thing, then if all these things fail, like you avoid you choose the minimum invasive anesthesia, minimum invasive surgical technique, you maintain the anesthesia level, everything, then only you go for any medications. Okay, so otherwise you will end up in hypotension. So this is one thing. And especially if you can, at that time you can consider labetalol or small doses of nitrates. And if it is like it's not controlling, then you can go for nitroprusside. Okay, you can go for hydralazine. Okay, people use also
Labetalol also if increment doses.
yes,
But it's little bit long acting. Yes.
Metoprolol, people use it, but actually the better choice is combined alpha beta blockade. Okay, so rather than
labetalol, sir, I told labetalol.
Yes, no, I have written both of them. I'm telling that
to...
people use metoprolol as well, but it's better to use labetalol. Okay, this is one thing. Then another thing which we were discussing, that how to control hypertension is in patient. It is better not to jump. Again, I am saying again, go slow, step by step. Okay, so you can consider phenylephrine if the patient's heart rate is not very low. Okay, because if you give ephedrine, what is difference between ephedrine versus phenylephrine?
Or mechanism of action, ephedrine is indirect acting drugs. It
Both
will
of them.
just
It has
increase
both
the
direct plus indirect, Jamil, please. It has both. It does not have only indirect effect. It has both direct and indirect. It has direct alpha-2, alpha-1 agonist action, and it releases catecholamines. Okay. So the response to catecholamines may be exaggerated in patient with hypertension. Okay. So if you compare between phenylephrine and ephedrine, it is better to give phenylephrine if the patient is not in bradycardia. Okay. Even if you have patient with bradycardia, you can combine phenylephrine plus glycopyrrolate. Okay. This is another way, because ephedrine, the response can be higher than expected. Okay, and rest of the things are the same. Look for fluid replacement. Okay, and actually one thing I have missed to stress when I was telling that when you will be looking at and you think that the patient has risk factors and patient's blood pressure is not controlled, you will be going for invasive investigations. Okay, investigations like echo, thallium scan, thallium scan, echo, also dobutamine stress echo. Okay, thallium scan to see the viability, and stress ETT. Okay, and further, if needed, the patient will go for angiography if needed. Okay, but usually you will be optimizing. And for example, if the patient is on one antihypertensive, you will be, actually it's not primary responsibility of anesthetist, but in exams in Pakistan they are asking. So if the patient is on calcium channel blocker, you can add AC inhibitors or diuretics or beta blockers according to the age and other factors. Okay, you will be making a combination to get at least 4 to 6 weeks to control the blood pressure.
100 billion. 100 billion.
Please, can you mute the mic?
Almost.
Okay, so this is how
Sir, I
you
have
will
a
be.
question.
Yes. Yes, Hassan.
Sir, I wanted to ask if a patient has reported to us in Preemptive clinic for cholecystectomy. It is elective cholecystectomy, and he is in grade 3 hypertension and he is non-compliant, and even he is not willing to take the medicines regularly.
Yes.
Are we in a position to delay the surgery? This was question asked in a viva, that why would we delay the surgery for if a patient
In
is
the
unwilling
viva,
to optimize
in the
himself, or
viva, yes,
sir,
I understand your question, Hassan. Actually, I tell you
sir.
something. That's why, because we are usually not in habit of discussing the patient with the surgeon, so we don't remember this answer. So we have to discuss risk versus benefit. The answer is you will outweigh risk versus benefit. Okay, risk
Right, sir.
versus benefits. Okay, like for example, you will be seeing that if you proceed, there will be chances of any unwanted event. Okay, so you have to get a balance, and the answer is this. Purely this is answer, because always surgical urgency is not anesthetist responsive, is not the domain of anesthesia. I cannot say that you cannot do the surgery. If we label it as urgent, it's like you can say the right of the surgeon. And if we consider that this this gallbladder is prone to even rupture, this is prone to have empyema, and there will be more morbidity if you don't remove it, rather than having patient hypertension. So if you are proceeding, you will be doing the risk stratification. Okay, so you will be doing all the concerns which I discussed with you. You can take intraarterial blood pressure monitoring. You can have good analgesia, multimodal analgesia. Okay, and all the things which I discussed. Okay.
Right, sir. Sir, in addition to it, I was asked that even if he wants to do his elective knee replacement surgery, and he doesn't want to take his medicines regularly, he clearly tells you, even then you cannot delay it, or you cannot,
No,
you are not
TKR is
one to
totally different.
postpone the surgery.
Listen, TKR is
Sir.
totally different. Okay. Of course, we are
Sir.
not, remember one thing, Hassan, that there are two different things. One is
Sir.
logistics and administrative problems, and one is academic problem. Okay. So the thing is that academics in the oral exam, they are not expecting you to prove that you will be proceeding with blood pressure of 200 by 110 for TKR. You will never proceed with it. You will never proceed with it because don't think about surgeons only. Don't think about only what is happening in our private setup. TKR, if you proceed, there are chances of hematoma. Okay, there are chances of failure. If you have heard that a patient underwent TKR, but still patient is having pain and patient is this is related with the unwanted surgical complications as well. Okay, so totally, because laparoscopic this cholecystectomy is never, actually we use the word elective, but it is not elective. It is a planned surgery. Okay, I hope I answer your question. Am I right? Are you listening to me? Am I audible to you?
Yes, sir.
Okay, so similarly, it's like this is what you will be expecting. We have discussed diabetes, so I will not go in detail of diabetes, but usually I will quickly that you will be converting oral hypoglycemics into insulin. Okay, long acting will be converted to short acting. Okay, and then you will be having the control of hemoglobin A1C or fasting blood sugar levels. Okay, and then again the same thing is that you will be expecting three things: DKA, hyperosmolar non-ketotic diabetic coma, or hypoglycemia. Okay, so remember one thing: hypoglycemia is more dangerous. People, when they are discussing about diabetes mellitus, they forget that more dangerous thing is hypoglycemia. If you want to have detailed discussion about it, you can have a look on the YouTube. We had discussed in detail, but basic theory is this one. Usually in the perioperative period, in the intraoperative period, IV infusion is better than bolus and better than subcutaneous. Okay, and you can have different sort of regimes, but usually there is a combined regime with the glucose, electrolytes, okay, and insulin, and there is a rate written on it. According to the blood sugar, we are controlling the rate. Okay, controlling the rate of that insulin infusion, which is combined with glucose, dextrose, electrolytes, and insulin. There is potassium. There is that's a sort of combined solution. Okay, and you have to repeat 30 to 60 minutes blood sugar, and you have to maintain. Another thing is that you have to optimize according to the stress of the surgery. That in the start of the surgery, the requirement of insulin will be higher, and by the end of the surgery, the requirement of stress will be decreased, and by the end of surgery, if you continue giving high insulin, patient may go in hypoglycemia. So this is what you have to anticipate. Okay, and as soon as patient is going in the NPO is broken, so you have to resume the normal routine. Okay, so this is what is very important in diabetic patients. So this is another thing, and you have to look for hypoglycemia. Again, the same autonomic dysfunction which can occur in hypertensive patient, there will be swings of blood pressure. So same thing will be occurring here. So you can just have the same precautions which we discussed in there. Okay, so what about anemia? You have a patient with anemia, and how will you optimize it? Again, when you are evaluating the patient, you have to decide whether the patient is compensated versus uncompensated. This is the first thing you should be knowing. Yes, people will be thinking that what is the reason for anemia? But actually, as an anesthetist, more than reason is whether it is compensated or non-compensated, and whether it is acute or chronic. Okay, whether there is acute volume loss or acute loss going on. Okay, and what is the problem in an anemic patient? Oh, sorry, the diabetic, I forgot to mention one thing which is very important. So I will tell that you have to maintain the loose glycemic control 120 to 150, or according to Jamil, less than 180. Okay, up to 180, less than 180. Okay, acute loss going on or not for anemia, blood loss. Okay, so what is the problem in anemic patient? Anyone, please? If you have a patient with anemia and you want to anesthetize, what is the problem?
Definitely, yeah, I just rule out the cause, as you already told. This might be chronic, or if it is chronic, definitely it's also related to some disease. Might be,
Yes.
some chronic inflammatory disease.
What is the result? What is the end result is decrease oxygen carrying capacity. Okay,
Yes.
because the main Jamil, unmute yourself, please. My mistake, I mute you. Unmute
It's okay,
yourself.
sir.
Yes, oxygen carrying capacity is decreased, so you have to look for it. This is the most important thing. Another thing is that there are certain things which you can do preoperatively is iron supplement.
Iron supplements, it may be oral or
Maybe
IV,
IV
depends upon
or
the
oral or
surgery.
IV.
Yes.
And if there
Yeah.
is some indication like that, you can give some erythropoietin. If it is certain conditions like
Patient with chronic kidney disease,
renal
yes, we
failure,
can.
or another, what else? What about sickle cell disease? What you will be doing in sickle cell disease?
Some
You
investigation
have to
about
no, you have
hemoglobin
to
S. We check the percentage.
yes, we have to see the percentage, and you have to if it is too low, or sorry, if it is too high hemoglobin S, then you may need exchange transfusion.
I think, sir, it should be less than 30%. Yes, hemoglobin S.
Yes, you confirm it. Okay, I cannot confirm the levels. So
Yeah,
this
I
is
think no, it should be less than 30%.
yeah. And then another thing is that, for example, if there is acute loss going on, you have to treat it like any upper GI bleed, lower GI bleed,
Hemorrhoid.
hematuria, okay, hematemesis. One thing is not in your control, usually, which is occurring in like in CRF, in for example, any cause with bone marrow suppression because of cancer treatment by like chemotherapy, radiotherapy, okay, or cancer itself. Okay, so you have to consider about these things, that you have to block the, if any nutritional replacement by not only iron, folic acid, okay, or vitamin B12, any replacement like nutritional replacement, and treatment of the cause of the anemia, evaluating the cause by, you can have this CBC with the peripheral blood smear, okay, peripheral blood smear, and you are looking for MCV, MCH, MCHC, okay. Another thing which is not directly related to anemia is to avoid or optimize or manage anticoagulants and antiplatelets. This is part of your management of a patient with anemia. Okay. Another thing, what will you be doing? You will be discussing with the surgeon to have minimum invasive procedure. Okay. What else you can do in anemia? You can consider about tourniquet. You can consider about positional strategies. What are these positional strategies? Can anyone tell?
Also, elevation of that part where is the operative site, and it's also definitely decrease the venous engorgement to decrease blood loss.
Yes, avoiding the stasis. Okay, like if you are having a head and neck surgery, so it is better if you have some head elevated. Okay, so this will be also management strategies in an anemic patient. Okay, then what else? Tourniquet. Then what else? Cell saver. Use of cell saver. Then what else? Using warm fluids. What else? Avoiding stress.
If it's possible, we can what you say autologous means hyper.
I was about to
Uh,
tell you. I will just give me anything which we have missed here. Now there is a little bit
okay, sir.
different scenario that you have a patient with suspected bleeding, not actually anemia. Okay, but you have a patient which is suspect that this patient can bleed. So in addition to whatever we have discussed, tourniquet will be there, positional strategies will be there, cell saver will be there, use of warm fluids, avoiding stress will be there. Now will be the use of that autologous, that you can have blood transfusion, blood, you remove the blood, save it, okay, and then you can use the same blood in that patient. That will be avoiding the blood from any other donor. You can use this terminology even if you have a patient with rare blood group. The same theory will be there. Then another, if you have a patient with suspected bleeding, you can have this hemodilution technique. Hemodilution technique is, one is normovolemic, okay, and other is hypervolemic.
Hypervolemic. Yes.
The basic theory in this management strategy, that you are decreasing effective RBC loss per ml blood. Okay, if you are diluting a blood, so the loss in 1 ml will be decreased. So this is the theory of hemodilution. So either you can replace in addition to dehydration, corrective dehydration, you are giving some more extra fluid so that the blood is diluted. So this is one theory. It is hypervolemic hemodilution. Or you just remove one pack of cells, one pack of RBCs, and then replace it with either colloid 1 times or 3 to 4 times crystalloid. So this will be, you can say, normovolemic hemodilution. Okay, so you have the strategy of normal volemic hemodilution, and then again the same thing, the stoppage or maintenance of the anticoagulants and antiplatelets according to the condition, according to the condition of the patient. Then you are avoiding the factors which can increase the bleeding. One of them important is hypothermia. Why hypothermia will result in bleeding? Platelet dysfunction.
Yes. The platelets decrease the functionality of the platelets.
Yes. So these are the things, because there are two different scenarios. One is bleeding patient. One is patient at risk of bleeding. And third is anemic patient. Okay. And in all these patients, an anemia patient may have high output, high cardiac output failure. Okay. Oxygen hemoglobin dissociation curve is shifted to right. Okay. Patient is having hyperdynamic circulation, hyperdynamic in compensated anemia. So you have to think about it. There will be problem in induction. What will be the effect in, we discussed before, IV induction versus inhalational induction and anemic patient. Yes, Jamil. Then what about cardiac depressant effect of of anesthesia medications. Okay. So Jamil, what will be effect on IV and inhalation reduction in anemia? Anyone, please?
Sorry, sir, your voice was distorted. I couldn't catch you. What is the concern of our IV or
IV
inhalational?
induction and
What due to?
inhalational induction in anemia. Because whenever their cardiac output is high, so IV induction will be fast.
Okay, sir. I understood. Yes,
And
in
inhalational
anemic
induction
patient there is high cardiac output. Yes, in
slower.
high cardiac output, and there is fast IV induction. And if we talk about the inhalation, overall it's decreased, but some depends upon the how the inhalation agent is the solubility.
It's have
But
more
the
effect on.
overall IV, yeah.
Okay. So these are the things which you should be considering. Again, I'm repeating: replacement, filling the gap, filling the gap of loss. Okay. And then choosing less invasive technique than the rest of the things. Okay. Rest of the things. Cell saver. Remember this word, cell saver. Remember the word tourniquet. Remember the, yes, and one thing I forgot to tell, antifibrinolytics. Okay. Antifibrinolytics also in bleeding patient. Another thing I could not tell you is low blood pressures, like hypotensive anesthesia
Induced hypotension anesthesia.
with, of course, the limitations. Okay. With the limitations and allowable limits. So, but hypotensive anesthesia, antifibrinolytics, positional strategies. And remember one thing, this is all for all residents. This is, if you memorize these things, this is like you can say chunk of your anesthesia management. In any bleeding patient, you can have the same thinkings in your mind. And another some monitorings you will be doing is point of care testings. What are those? Thromboelastography, ROTAM.
Tech, rotin, yes.
Okay. Then INR. Then ACT may be needed. Okay. Then this HemoQ. HemoQ is bedside monitoring of hemoglobin. Okay. Okay. ABGs in a patient with suspected bleeding. So you will be doing all these things. Any questions, please? I would like to listen from some of the resident. Rabia, are you understanding? Any confusion? Hassan?
Yes, sir.
Yes, please. Because this is very important topic. Okay. So I think we have covered a number of things in this aspect. Some I will try to cover some more. Like I had missed. What about smoking? Yes, Jamil.
Yes, sir. Smoking is also somehow we can preoperatively can what you say the stop or quit the smoking to
Ideally,
optimize the
ideally,
respiratory
what is the best time
function.
for
It should
stopping?
be at least 8 weeks.
4 to 6 weeks. Okay, 6 to 8 weeks.
Yes. Six,
If
6
you
to
are
8 weeks will be
minimum,
definitely.
what will happen in 12 hours?
12 hours improve the oxygenation. If we stop 12 hours before the,
Carbon
and
monoxide
at
level
least
is
if we
decreased. Jamil, this answer I'm expecting better answer from you. Carbon monoxide level will be decreased. Nicotine levels will be decreased. Oxygen carrying capacity is improved. Okay. Recall it.
okay.
What else? What changes you are wanting? You want mucus clearance and
Milk
production.
clearance, sir, yes, it will help if it's 3 to 4 weeks before. If we stop, then it will improve the secretory function of the lungs. It will decrease the
Yes.
secretions and mucus production. And
C.
if 6 to 8 weeks, it will increase the functionality of the epithelial of the airway tract. It's then comes
I will
less
just
respiratory complication and post-operative.
because this topic should be on your tips. This is a paper out sort of thing. Okay, because no majority exam you will not be finishing without considerations about the smoking. Okay, so just a second, I will show you. Actually, we are just trying to cover as many points as many because otherwise we can discuss all these separately. Just a second. I couldn't see the messages. I apologize for that because I think I have some problem in my internet. Okay, can anyone recall the exact timing? Because I always forget these timings. Then what happens in one day, one happen in 1 week, one happen in 2 weeks. There is because you should be knowing it. What is the time in which there is actual more problem than advantage? Okay, so you see.
Means you're talking about the smoking, sir?
Yes, I'm talking about smoking. Okay, so
Yes,
actually,
if it's less than 2 weeks, then it's more. Now then reactionary there is more secretion of secretion production and more
what is
respiratory
what
complication.
do what is 1/12? Just a second, please. You should be consulting always. I will suggest you to have printouts of these FRC and mind maps, and please do them. They are very good. They are very good source of revision. 1/12 means, what do you mean by 1/12? Is 1 month.
1 month.
Okay.
1 month, less than 4 weeks. Yes.
Yes. So gradually there is improvement in airway hyperreactivity. Not only clearance of carbon monoxide, there is decrease in negative inotropic effects. Like nicotine and carbon monoxide effects will be decreased. So there will be increased oxygen carrying capacity. Okay. So that's what they have just mentioned here, that you have to think about it. So remember one thing, this is one of the most important thing. Okay, you should be knowing about it. What else? Similarly, if you are in Pakistani exam, maybe it will not be asked, but in international exam, alcoholism. Okay, I cannot recall number of things related to alcoholism, but usually it is the amount the patient is taking and the effects. Okay, because there is enzyme induction.
Most of the there is.
Jamil, you know about how many packs and how many, do you remember where we learned them when we were appearing in FCIM, right? But now I've forgotten, we have not discussed this, but you have to stop alcoholism before it will have effect on enzyme induction, and patient may have withdrawal symptoms.
Yes, especially in chronic, the withdrawal system is early. After 48 hours, there is a withdrawal systems, and
If you
if
have a
we
chronic
sell them,
alcoholic, what will be the effect on MAC?
it will in chronic it will increase the MAC, and
Increase
in
MAC
acute,
requirement.
yes, decrease the MAC in acute situation. In
And
acute,
enzyme induction, there will be increased dose requirement. Okay, because of liver enzyme induction. So you need higher doses. So these are few things which I recall. We don't have time for discussing alcoholism in detail. Just a second. Actually, in the morning, I just wrote down some of the points which. Just a second. You understand the concept of optimization and anticipation? Do you understand? If you have a patient on steroids, okay, you have to consider steroid replacement.
Steroid replacement depends upon the dose and the duration of the
So you
and
should be knowing interconversion, because I don't have the time to tell you each and everything in detail, but you should be knowing the interconversion of hydrocortisone versus dexamethasone, equivalent doses. It means equivalent doses. Okay. Then the other ones, cortisol, methylprednisolone. You should be knowing the equal doses. Can anyone recall it? I think
prednisolone also.
1 milligram cortisol is equal to 4 milligram of dexa, and 20 milligram of
No, sir. I
hydrocortisone.
think
I cannot recall, but
no.
I
I
will leave.
think yeah.
I will leave it, but you should be knowing the interconversion, please. Okay. We will discuss in detail. So but I'm just trying to tell you what are the possible optimization on or anticipation you should be needing. If you have a patient on different medication, if you have a patient on antidepressants, what are the considerations? You should be avoiding indirect acting this one like ephedrine. Why? There is high catecholamine levels. Okay. So you would be using phenylephrine versus rather than ephedrine. You will be avoiding tramadol. You will be avoiding panchronium. You will be avoiding pethidine. You will be avoiding ketamine. Okay. You understand that if the patient is on antidepressants, should you stop them or no?
Antidepressants depends upon the generation, and
Risk versus
then we
benefit.
have to.
If they are asking
Yes.
you risk versus benefit, usually you will be discussing with a psychiatrist. Okay, according to the clinical condition of the patient, usually you can continue. Okay, it's not contraindicated. MA inhibitors. What about MA inhibitors? SSRI and
Yes, we
TCAs.
have
I
to
don't
avoid
think
the interaction. Yes.
MO inhibitors can create more problem. Okay, so you have to discuss about MO inhibitors. Okay, and you have to avoid tachycardia containing the drugs which are causing tachycardia, like pethidine. What is the effect of pethidine, Jamil? How
Sir,
pethidine cause?
in the interaction, it will give the exaggerated hypertension in patients who are taking monoamine oxygen inhibitors.
Yes.
Or it's also you have avoid with SSRI like tramadol. It's also have some interaction with these drugs.
If the patient is on MO inhibitors, there are chances of patient going intraoperatively to serotonin syndrome.
Serotonin syndrome, yes, especially with tramadol.
Okay, so we have to avoid medications which can actually causing tachycardia. But usually you remember the common drugs which I am telling you: tramadol, panchronium, pethidine, ketamine, ephedrine. Okay, and also some people consider histamine releasing drugs also. Okay, so steroids, you should be knowing, you have to give the replacement doses. You should be knowing the equivalent doses of steroids. Okay, and okay, if you have a if you have a patient with the because there are so many things which I want to tell If you have a patient with difficult IV lines,
Sir,
or
if you allow me, I can quickly tell the equivalence of the steroids, if you
yes,
don't
please
mind,
tell.
please. I remember mnemonic as a diabetic DM at PHC. Diabetic means D for dexamethasone, 1 milligram of dexamethasone. M for methylprednisolone, it will be 4 milligram of methylprednisolone, diabetic DM. PHC. P for prednisolone, it will be if
5 milligram.
5 milligram is 1 milligram of dexamethasone is equal to 5 milligram prednisolone. H for hydrocortisone, it will be
20.
20 milligram equal to hydrocortisone.
And
As
then it
C
is
for
1.
PHC, C for cortisone, it will be 25 milligram of cortisone. Yes,
25.
diabetic DM at
Okay, so
PHC.
yes,
Yes,
uh,
cortisone 25 is equal to 1 mg of
dexamethasone,
dexamethasone.
methylprednisolone, prednisone, and hydrocortisone, and 25 milligram of cortisol. Okay, so
And
I think,
cortisone.
yes, so I think I will just try to have some similar. We will continue with the same topic because this is a chunk of your Viva. Okay, so tomorrow we will try to discuss some of more things. Okay, thank you very much.